Good afternoon. My name is Whitney Witt, and I am the inaugural Dean of the College of Health at Lehigh University. I am so excited to welcome you to the second in our ongoing Population Health Colloquium Series. The Population Health Colloquium is a faculty organized series that will continue throughout the summer and focus on COVID-19, examining the most vulnerable populations, social determinants of health, and shining a light on the most long-standing health inequities. I'm delighted to introduce you to our two leading experts who provide an overview and comparison of several different techniques, computational techniques for forecasting COVID-19. Participants will also learn about incorporating expert judgment into infectious disease forecasts. So I want to now introduce our speakers. Dr. Skinner is a renowned expert in advancing epidemiological methods. Most recently, he served as the Director of Data Strategy at IBM Watson Health. And today, Dr. Skinner will discuss several different computational models to predict COVID-19 in the US and around the globe. And we are so fortunate to also have Dr. Tom McAndrew on the panel. He is a leader in the field of biostatistics and data science. And today he will be discussing how combining human judgment and statistical models can improve forecasting for COVID-19 as we follow epidemics and pandemics right now, and using COVID-19 as an example. And I'm happy to announce that Dr. Andrew will officially join us as an assistant professor in the College of Health in July. And Dr. McAndrew is Lehigh's very first biostatistician. So without further ado, I am going to now turn it over to Dr. Skinner. Dr. Skinner.
Thanks very much, Dean Witt. It's a pleasure to be here today talking about this timely topic and hopefully providing some perspective on how epidemiologists think about COVID-19 and how they develop and use computational models for forecasting COVID-19 and other infectious diseases. Could I have the next slide, please? So models are tools. There's nothing magical about them, but there's been a lot of discussion of them in the popular press and on social media. So I think it's important to think a little bit about what models are, what they can and can't do. Epidemiologists use models to capture and communicate ideas about how disease works. These are simplified representations of reality that we put into a computational format. And we build models using incorporating our beliefs and assumptions, and then try and use them to quantify our expectations about how disease will affect the population. We can then look at these expectations and then compare them to the observations that we see in the population about the number of cases, the severity of the illness, the course of the illness over time. Models can be useful for answering questions and forecasting outcomes for decision makers. The first question we always ask is this an epidemic? We observe some new occurrence of symptoms and illness in the population. Is this expected or is this something new? How many people will become ill? How many will die? What can I do as an individual to stay healthy? These are all questions that models can help us to understand better. Models can also be used to help compare potential interventions and thinking about policy changes or biomedical interventions that might help us reduce the infectious potential of the disease or the consequences in the population. These include things that we're all familiar with now, like, is social distancing important? Should we wear masks? When do we need to think about mass isolation and quarantine? Next slide, please. It's important, though, to know the following mantra. I say it to myself frequently. That this comes from Professor George Box from the University of Wisconsin. All models are wrong, but some are useful. And I would go on to say that that not all models are useful for all questions. Models are usually designed and targeted to answer specific questions or a specific set of questions. And the application of models to try to answer questions for which they weren't really intended can lead to problems. So let's keep this in the back of our mind as we think about these models. We need to accept that all models are wrong, And we need to evaluate more whether the model we're thinking about is a useful one, and for what might it be useful. Next slide, please. So I'm going to talk about three categories of models that have been used recently for describing COVID-19, the epidemic, and also for forecasting what we expect to happen going forward in the epidemic. The first is what I'm going to call a statistical model, and there may be differences in terminology across disciplines. Then we'll talk about the SIR model, a favorite among epidemiologists, and finally, an agent-based model. Next slide, please. So the statistical model of COVID-19 is simply making a forecast based on an underlying belief about the distribution of events in the population. This can be useful for forecasting, but in looking at how things will play out going forward, but the statistical model doesn't explicitly account for what we know or we think we know about the transmission dynamics of a particular infection. So this is akin to thinking about the famous Gaussian curve, the bell curve, and thinking, okay, we've seen this disease in other populations. We think that it's going to have a similar pattern in our population. Let's see what it looks like if we apply this disease pattern in our population and where we think we are in that timeline. The IHME model, which has become pretty famous in the popular press and has been used for some policy decisions, is an example of a statistical model. And this was one of the first models to come out that did something really important, which was, and rather than looking at the entire United States as one lump population, it started to break the population down into individual state level populations, and then combining those expectations and distributions back into the United States. There's been a lot of back and forth about the strengths and limitations of the IHME model. Can we have the next slide, please? Here's a look at, this is from the Washington Post, of a series of forecasts for the peak of the deaths of COVID-19 back in April that came out of the IHME model. And you can see that over time, as the model was updated, the peak had a slight shift in the date of application of the peak, but also a pretty large shift in the magnitude of the expected number of deaths. There have been a lot of discussion about ways to improve this model, and they've been updating the model since then. I will say that if you go back to the very first release of the model, in terms of the cumulative number of deaths, their expectation from the first date that they released it was about 80,000 deaths by August, with a confidence band that spanned 40,000 to 160,000. And so far, the prediction seems to be within their confidence band for that particular outcome. Can we go to the next slide, please? So the second type of model used for this type of forecasting in the epidemiologic context is the SIR model. S stands for susceptible. That's people who are potentially infected, who could become infected. I is for infected. That's people who have acquired the disease. And R is for recovered. And the recovered category also includes those who die, who are no longer infected. So the SIR model basically lumps the population into these three buckets. You're either susceptible, you're infected, or you're recovered. And the model then looks at the probability of transitioning from each bucket to the next bucket over time, and then models based on those parameters, the speed of the increase and then decrease in the population of the pandemic in the population. Next slide, please. Like all models, the SIR model includes a number of assumptions that are usually not exactly met or well met in reality, but they're important to understand in terms of interpreting the output of the SIR model. The first assumption is that there's a well-mixed population, that any given pair of individuals are equally likely to meet, that the population is homogeneous, that is, everybody in the population is equally likely to be infected, and that the distribution of the duration of infection is exponential. That is, as soon as they're infected, they're immediately infected, they can infect someone else, and the likelihood of recovery is not related to how long they've been infected. And finally, common to a lot of statistical models, like the SIR model, a large population is required. And ideally, this population is infinite, but obviously that's not true in reality. Next slide, please. So the question for the SIR model, and the same question we ask for the statistical model like IHME is this useful? Well, there's certain characteristics from the SIR model that we can take out and find very consistent uses for. The first is the now somewhat more famous than it used to be R value. That's the basic reproductive rate. We can see on the along the columns there. It's the number of secondary cases that are caused per case. And then along the rows, we have the percentage of the population who are susceptible. And a consistent feature of the SIR model is we know that if we multiply the R value times the S value, and if that number is greater than 1, then an epidemic can occur. So in a population that's 100% susceptible, that's the bottom row there, you can see that you need essentially an R value greater than 1.2 to have an epidemic occurring. And so this leads us to several conclusions based on the assumptions. If I could look at the next slide. Oh, back it up, please. Missing a slide I thought I had there. So one of the conclusions is that the only reason, no, I'm sorry, let's pause that there. My slides are out of order from what I expected. Go to the next slide and we'll talk about the agent-based model, the third type of model. So advance to the next slide, please. So this third type of model is the agent-based model. So rather than thinking about the population in different buckets, we think about individuals in the population. If we look at the figure on the left, each dot in the square represents an individual. And like the SIR model, each of those individual dots can either be healthy or susceptible. They can be sick, they can be recovered, or they can be dead. And the way the agent-based model works is it runs forward. It allows these dots to move freely in the population. As they encounter one another, they have a probability of transmitting disease to the next person. And then they have a probability of recovery. And then the transmission can be continued forward. And you can see that in this case, the disease transmits rapidly, people recover rapidly, and then there are a fixed number of deaths over time. Can we go to the next slide, please? So we have 3 different types of models. And within each of these 3 different types, there are any number of different characteristics and parameters that the modelers can select and choose based on different assumptions and different needs. And this will lead to some level of apparent disagreement in the models in terms of the outcomes that are being modeled and looked at. And it comes down to a matter of expert judgment and understanding of the models, the assumptions, and the outcomes in terms of making these decisions and answering questions from the models. In general, it would be great if decision makers looking at models incorporated the modelers or people who are familiar with the models and helping them to interpret the models that come out. And again, the specific questions that are being asked need to be appropriate to the model that was designed for those questions. Having said that, across the types of models and across the different sub-models that go into it, there are a number of things that are consistent across all the models. So if we could go to the next slide, we can talk about those a little bit. So the first thing that's consistent across every model for COVID-19 is that the pandemic will end when there are no more infected people. A follow-on condition for that is the pandemic can end if there are no more susceptible people. And finally, a condition that would satisfy this is if there are enough recovered people or people who have been vaccinated that could prevent transmission between pairs of susceptible and infected people, and this would lead to herd immunity. I think an important thing to note about herd immunity is that it is not itself a strategy for dealing with pandemics unless it's in the context of vaccination. Herd immunity without vaccination basically means that everybody who can get sick does get sick. Can we go to the next slide? The the other consistent feature from all models is that the ways that you can prevent or stop an epidemic would be to vaccinate or reduce the fraction of susceptible individuals, or to reduce the transmissibility from an infected to a non-infected person through isolation at an individual level. That would be like contact tracing and isolation, or through social distancing, which is a more general population-based isolation strategy. Finally, another way to address a pandemic would be to increase the recovery rate by treatment. That is, getting people to recover from infection more rapidly, and that would reduce the period for which they were infectious. That would require, of course, an effective and widely available treatment to accomplish that. So with these in mind, it's apparent from any modeling approach that there are a number of factors to keep in mind. It's not sufficient to look at a model and say based on theory that it's wrong versus another model, that there's some level of validation and calibration that's required. But also it really does benefit the decision makers to draw upon the judgment of those who have worked extensively with these models, who have been involved in developing them, and using their insights into how the models operate to make statements about the likely course and forecast for the epidemic. With that in mind, having a method to collect information from a wide number of expert forecasters would be valuable. And that is what my colleague, Dr. Tom McAndrew, will talk about now.
Hey everybody, I'm Tom McAndrew. I'm a postdoctoral fellow at UMass Amherst in the School of Public Health and Health Sciences in the Reich Lab, and a soon-to-be incoming assistant professor in the College of Health at Lehigh University. Hal, you gave a great overview of computational models. I appreciate that. But let's look at a different approach. Let's look at aggregating expert opinion on COVID-19. Next slide, please. The first expert survey that I conducted was on February 17th. I want to give you a little bit of context about when that was. Late December, SARS-CoV-2 was reported in Wuhan, China. The US announced their deaths, the first death due to COVID-19 just after our first survey. On March 12th, the WHO announced COVID-19 as a pandemic officially. March 25th, the IHME model presents its first forecast to the public. In early April, the Forecast Hub, which is a collection of ensemble models, was online just in the beginning of April. And to date, we have 1.9 million cases and 105,000 deaths in the US. Next slide, please. Now on February 17th, we asked experts 3 questions. I'm going to read the questions for you. Do you think that the confirmed case count of COVID in the US reported by the WHO on April 1st, 2020 will exceed 100? Second question, as reported by the WHO this Sunday, February 23rd, will the number of cumulative confirmed cases in the US with possible or confirmed transmission outside of China exceed 5? The final question we asked, what is the smallest, most likely, and largest number of all cumulative confirmed cases imported in local transmission? The WHO will report this coming Sunday, February 23rd. Let's take a look at the results. Next slide, please. So here we have the 3 questions and the results from the experts. Next slide. And here's what they said. 9 out of 15 experts gave more than 50% probability to there being more than 100 cases by April. The next question in the center, whether or not there'll be more than 5 cases outside of China by February 23rd, that was 1 week ahead at the time. 8 out of 15 experts gave more than 50% probability to that event occurring. Finally, in the far right here, on the horizontal axis, you have each of the 15 experts that participated in this first survey. On the vertical axis, the predicted number of cases by February 23rd. And you have their smallest, most likely, and largest from bottom to top prediction. Now, we also know that there was 35 cases reported on February 23rd, and you can see here the expert forecasts do a good job covering that event. Now, I want to take just 1 second to step back and look at the goal of forecasting. Next slide, please. The goal of forecasting, at least for me, is to provide public health officials actionable information, information that we can give them to support decision-making, information they can use. Here's 3 examples of ways they can use our forecasts. The first one are public health campaigns. In this example, it's seasonal influenza. So they have this marketing campaign, fight the flu, get vaccinated, don't touch your face, wash your hands, cover your cough. This is one way that we can help public. Second way is to make sure vaccine stockpiles are big enough to meet demand. A third way in the far right here, this is actually a picture from the 1918 pandemic, is to make sure that hospital burden is not too great and that again, we can forecast the demand and make sure that there's enough staff there. Next slide. Back to the experts. So if you were an expert in that crowd on February 17th, we would define you as an expert as follows. A researcher who spent a substantial amount of time in their professional career doing one of 3 things: designing, building, or interpreting models to explain and understand infectious disease dynamics or associated policy implications in human populations. That was the criteria we used to define an expert. We solicited expertise in a couple of different ways. One is by email. It turns out the modeling group of infectious disease people is a really close-knit research community, and many of my colleagues are also my friends. So we sent out personal emails to them. That was one way. We also sent out emails on listservs for other modeling infectious disease groups. We also included a Slack solicitation to a channel that was specifically modelers of infectious disease related to coronavirus. And to date, we have 41 different experts. Next slide, please. If you were an expert and if you joined this group of 41 different people, you would receive an email like this every Monday. It would say, "Dear so-and-so, thank you for participating," and we would give you a summary. That's this link here where it says 2020-49 COVID expert report, a summary of last week's forecasts. That's the first paragraph you'd receive. The second paragraph, we would remind you about data anonymity and that your forecasts are going to be de-identified. The third paragraph, we would tell you when this survey is going to close. Surveys were sent to experts Mondays at 10 a.m. and they closed Tuesdays at 4 p.m. Finally, we'll give you an option to click that link and take the survey. You're also allowed to opt out of future emails. And I think crucially, we also gave experts feedback on their forecasts. So an email like this, a personalized email, is a social contract. And behavioral economics has shown that social contracts are much stronger than business contracts. This is also a default. This email arrives in your inbox every Monday. It's not something like a platform you need to log into. And because of these 2 factors, we had really good participation rates. I think crucially, to help expert accuracy, we gave them feedback on their forecasting results in 3 different ways. We gave them the original forecast they made, the true report, if it was available, and we also gave them the forecast that their expert friends gave. So they got 3 different ways to assess how well they've done. Next slide, please. Now, if you click that link and you take the survey, you might see something like this. On the left is your computer screen, and on the right is cell phones. So we supported both mobile and desktop versions. And I just want to show here the anatomy of a question. So let's look at the left here. The first thing we do is provide you some background information about the question we're going to ask. So in this case, it's about the total number of positive COVID cases in the US. So we gave them a picture of time on the horizontal, the number of positive COVID cases in the US on the vertical. And we said, as shown in the table and figure above, the COVID tracker, which is a specific surveillance system, reported 1.3 million total positive cases of COVID-19 Monday, May 11th. So there's just some background information for them. The next part of the question is the ask. So we asked in this case, what is the number of positive cases in the US that the COVID tracker will have in their daily report Sunday, May 17th? The last part of a question is how we want them to answer. In this case, we provided a set of intervals where the true number of positive cases could fall, and we asked experts to assign a probability to each one of these intervals. This is just a quick overview of the anatomy of a question, how we asked experts, who we recruited. Now let's get to the good stuff. Next slide, please. Predictions. So I'm going to showcase 4 different predictions that experts have made over the course of just about 2-3 months now. Next slide. First one's deaths. Next slide, please. So the question we asked experts, over the last 9 seasons, the CDC estimates that the seasonal death toll from influenza has ranged between 11,000 and 95,000. That's that background information. Here's the ask. What are the smallest, most likely, and largest number of deaths that will occur due to COVID-19 by the end of 2020? Here we allowed experts to give two different types of answers. One we call a triplet, which is the smallest, most likely, and largest number of deaths. And one is a percentile question where we asked specifically for the 5th percentile, 50th percentile or median, and 95th percentile. Let's look at the results. Next slide, please. So on the horizontal axis, you have the date the survey was issued to experts. We issued this question 4 times. On the vertical axis, the predicted number of deaths by the end of 2020. Now above each of these bars here is the true reported number of deaths at that time and the true number reported confirmed cases at that time. Below this figure is just some contextual information about policy, public health policy, and social media surrounding these forecasts. In the blue bar here, we have the 5th and 95th percentile from all experts' consensus forecast, and the black dots are the median estimates. First observation, next slide, please. Experts predict between 150 to 250,000 deaths by the end of 2020. These estimates are fairly consistent over time, and a lot has gone on from March 16th to April 20th. Next slide, please. Another observation is how stable they are. These first 3 surveys predicted something like 225 to 275,000 deaths, very narrow range for the median. And this most recent survey predicted 150,000. Next slide, please. Even though there's pretty stable predictions, there is a broad uncertainty in the number of deaths by the end of 2020 that experts put on these events. So you see in the first survey here, it's below 50,000 to above 1.1 million predicted deaths by the end of 2020 in this 90% confidence interval. That's a really broad range. That broad range kind of shows up again in the next survey on March 23rd and March 30th. And there's a slightly smaller uncertainty in April 20th, but it's still very big, something like below 100,000 to above 500,000. Now, if you notice, the first 3 surveys look a little bit different than this last survey's prediction. Thank you. And that's because the first 3 questions we asked were triplets, the smallest, most likely, and largest number of deaths they expect. This most recent survey asked specifically for the 5th, 50th, and 95th percentile. So the way you ask the question depends on the results you're going to get. That's something important to earmark about experts. Next slide, please. Okay, let's talk about hospitalizations. Next slide. The question we asked, which of the next 6 months will see the highest total number of hospitalizations nationwide in the US for COVID-19 illness? Assign a probability to each month representing the likelihood of peak US hospitalizations occurring in that month. And there's 2 requirements. Your probabilities have to be between 0 and 1 and sum to 1. Next slide, please. Some results, some major results right off the bat. On the horizontal axis here, you have each of the different months, March through September. On the vertical left, there's 4 surveys where we asked this question. On the vertical right, again, contextual information about public health policy and social media at the time. In blue are the probabilities experts assigned. You see that April, May, and June is predominantly the forecast where experts think hospitalizations will peak. This is when they think it'll peak. Next slide, please. Now, if you look at March, April, May, and June, the probabilities assigned to all those months summed up is fairly consistent over time. On March 23rd, it was a 0.76 probability. On April 13th, it's a 0.84 probability. But overall, even though there's been a lot of things that have happened over this time, the probability experts think hospitalizations will peak is roughly in these months. That said, next slide, please. There's still an appreciable probability assigned to July and August. Next slide. Okay, we talked about hospitalizations a little bit. How about the total number of SARS-CoV-2 infections? Next slide, please. The question we asked, this is just an example. As of Monday, March 9th, what percentage of all COVID-19 infections in the US, either symptomatic or asymptomatic, do you believe were reported as confirmed in the table above? We had a table of cases above. Please indicate the smallest, most likely, and largest percentages below. Next slide, please. Here are the results. This is a big figure. Let's take our time and unpack it one by one. Next slide, please. So we asked this question 6 times between March and April, and that's what these 6 vertical lines are. In green is the expert predictions. The bars are the 10th and 90th percentile, in other words, an 80% confidence interval. The green dark diamonds are the median. We also included computational models here in this figure. In blue is a sentinel event estimate by Lover and McAndrew. I'm the McAndrew in that situation. In red is a stochastic simulation by Perkins et al. In yellow is seed event model by Trevor Bedford. And this most recent computational model was called a complementary approaches model by Liu et al. In purple. I also included the number of confirmed cases, the reported confirmed cases, in dark gray. And on the vertical is the total US SARS-CoV-2 infections predicted by all of these models and the experts. Overwhelmingly, I think something you see right away is that the expert predictions in green tend to agree with computational estimates. Next slide, please. That said, if you look at this dark gray mark, experts overall predict many more total infections than are confirmed. And finally, the second figure down here, talking about fractions of confirmed infections. On the horizontal axis is the percentage of total SARS-CoV-2 infections thought to be confirmed by experts. On the vertical left are the 6 surveys when we asked experts these questions. And the blue is the probability they assigned to each one of these percentages. You see overwhelmingly that experts think a small percentage of all SARS-CoV-2 infections are reported in the US. I also outlined in dark blue the median, and that median is fairly consistent from March 2nd to April 6th. And that median is roughly 14 to 16%. Next slide. Okay, last but not least, confirmed cases. Next slide, please. Here's the question we asked. So we showed that table that I showed in earlier, and we just asked for the number of total confirmed cases in the US that the COVID tracker will have in their daily report that following Sunday. So a 1 week ahead prediction. And here's an example of a way we would ask them. They would provide probabilities to intervals that we set up. So in this case, it was less than 850,000 and more than 1.1 million. Let's look at the results. Next slide, please. So here on the horizontal axis, now it's not the date that the survey was issued, it's the date the forecast was meant to be for. On the vertical is confirmed COVID-19 cases. The blue bar is the 5th and 95th percentile, in other words, a 90% confidence interval for experts' predictions. The dark blue circle is their median prediction, and the black circle is the true reported cases from this COVID tracker surveillance system. 2 things to note here. Overwhelmingly, the 90% confidence interval covers the true reported cases on 7 out of 8 occasions. That's 87% at the time. So experts seem to be fairly calibrated for predicting confirmed cases 1 week ahead. Even though they seem calibrated, their accuracy isn't great, especially for the first 5 surveys. You see that the median, this blue circle, is quite a bit below the black circle, the true reported cases, for the first 5 surveys. The last 3 surveys, they did much better. And you see that the black circle and the blue circle are much closer together. So experts were able to learn over time. Next slide, please. Just a quick recap. Experts gave fast, calibrated forecasts of the early COVID-19 outbreak to support decision-making directly. Next slide, please. In the future, what are we going to do now? We have all these computational models that Hal overviewed. What should we do? One approach is to shift to a complementary role for experts to support decision-making and specifically to support these computational forecast models. In the future, we also plan to work with we have been working with Good Judgment Inc. and Metaculus, 2 excellent collaborators who have crowdsourcing platforms, and we intend to continue working with them, making forecasts. One other future bullet point is to switch our expert pool from modeling of infectious disease to experts in vaccines and therapeutics and ask them some questions. Next slide, please. I think it goes without saying to thank my postdoctoral lab at UMass Amherst School of Public Health and the Reich Lab. They have been just great, great collaborators, really good scientists. And I've made friends with all of them, really close friends. Next slide, please. I think it goes without saying, but I'm going to say it anyway. Thank you to all the experts that have just participated. In this case, all the experts shown here participated in at least 2 surveys. And they've just been a great team of people and all really, close friends and excellent collaborators and really brilliant scientists. Thank you. Next slide.
Wonderful. Thank you so much, Tom, for that. And I also want to thank Hal for taking us through that very clear overview. There are a couple of questions that have come in about the incorporation of other types of expert information. So from the community level, individuals, those kinds of those levels of information, in addition to the public health experts and the vaccine related organizations. So that was one of the questions.
Yeah. So I think that something experts can provide, kind of, or not even just experts, people can provide in addition to computational models, is we're able to incorporate subjective information, right? We are able to read articles, read news and media, and see what's happening in the world and make well-educated guesses. Where computational models usually need kind of objective, really structured data sets. So I think something that experts offer is this kind of incorporation of subjective data in their forecasts.
We had another question about something specifically related to the methods in your study. Tom, how many experts opted out of receiving emails regarding the surveys, and did you re-enroll any additional experts if this number was significant?
Yeah, we sent the solicitation out to well over 100 participants, and the 41 that did agree never opted out. So once they agreed, they stayed the whole time. And if an expert did opt out, we didn't approach them again.
Okay, great.
Yeah.
Hal, how do you? Another question came in. How do you think some of these methods that have been around for a long time in terms of following infectious disease, what is different about COVID-19 in terms of the methodology that we need to be thinking about? Clearly, one example has been Tom's approach. Could you talk a little bit more about other methodological approaches that are being considered?
Sure. I think that that changes over time with the development of an epidemic. So what epidemiologists were doing at the very early stages was very sort of historical, almost, basic calculations to try and get a handle on just what was going on. And as time progresses, then we can incorporate new sources of information, more sophisticated analyses to try and drill down into the details of the dynamics of the infection to look at a bigger population health perspective. What subpopulations are at highest risk for severe illness or most vulnerable to infection? What other opportunities would we have for informing policy in those directions?
Yeah, and I think that's a very, very critical, important piece of information that we need to reflect on. Part of, I think, one of the challenges that we have is that many of these models don't stratify by different determinants, or don't incorporate those social and behavioral and environmental determinants, and sort of how do you get around that and thinking about a population health model linking in all the things that we know affect health, that could give us better estimates of communities who may be more vulnerable than others, and we know that in advance because of patterns over time. Or so I was just curious about trying to implement and operationalize the population health model in the context of COVID-19.
Yeah, I think that's a great point. I think one of the things that it would be good to see, maybe a lesson learned in this case, is to get systems in place that can be ready to capture the kind of information we would want to have. I think I still hear colleagues saying that they're clamoring for more detailed information about the cases that are occurring so that we can get a better sense of this.
Yeah, we have another question coming in regarding the SIR model. Is it worthwhile to use an SEIR model for COVID-19 where E is exposure? This is a period where the person has been exposed to the virus, but not yet infectious. Hal or Tom, did you want to take that?
Yeah, I think the SEIR model is kind of the big sibling of the SIR model. And anytime we can add in more parameters to a model, I think we're tempted to do it. The concern every time you add a new parameter like an exposure into the model is you have to have some degree of confidence in the information you're getting about that. And it would be great to have detailed information about exposed but not symptomatic people or people who would fit into the E category. And so you fully expect to see, and there are out there SEIR models that could potentially be more informative or useful than SIR, but it really does come down to the quality of the information about that. But Tom, feel free to weigh in on that too. I think.
Yeah, just to follow up with what you're saying, SEIR model is absolutely worthwhile, and I would say the majority of models, when they take this dynamical systems approach, they do go SEIR at least on large population scales, and sometimes they will do SEIR on smaller kind of county or even zip code region levels. So, absolutely, is it worthwhile to do an SEIR model? I think the answer is yes.
Well, and I think the other thing that we need to keep in mind when we talk about SEIR models is that we're also not talking just about individuals, but also what about pregnant women and those kinds of critical exposures to the fetus that may have implications for, for the life of that child and subsequent generations. So I think that's really good point.
You bring up a really good point. A lot of SEIR models and SIR models in general stratify by spatial parameters, right? But I haven't seen a ton, at least in the past couple of weeks, that's stratified by different, types of population, right?
Yeah. I think, in terms of exposures, I think, there's so many interactions with other things, right? Interactions, exposures, and infection and onset of infection, being infectious, depends on so many different things, and the way that we're seeing things play out in people with chronic conditions, their window of going from 0 to 60 may be very different than someone else. There's that sort of, when you're just looking at an individual over time. But then when you cut the pregnancy part, it's you're talking about sort of also windows of exposure for two people. So because 40% of pregnancies are unplanned. So it's just an interesting aspect of it, I think. Yeah. Okay, let's see. So we have another question in here. Have people done modeling regarding the success of various treatments as experience with the disease has progressed? And I might just sort of as a moderator attenuate that a bit to include treatments like policy changes, not just treatments in terms of healthcare, but so that would be my only addition to that question.
I was going to say that is the I've seen a lot of models now that aren't necessarily modeling direct treatment, but they have modeled social distancing, stay-at-home orders, and policy changes. And one of the ways they do that is remembering back to Hal's presentation of the SIR model. Mm-hmm. Contact rate in that model is constant.
Mhm.
One of the ways to model stay-at-home orders or social distancing is to let that parameter vary over time and let the contact rate reduce. And so you will see models doing this and having kind of time varying parameters like contact rate to model social distancing stay-at-home orders. But yeah, it's a good question, and it is being done right now. In the expert realm, the way that I asked some questions about the impact of stay-at-home orders, or really the impact of relaxing stay-at-home orders. I asked counterfactual.
Mm-hmm.
So I would ask, for a particular state, they are planning to relax stay-at-home orders maybe next week.
Mm-hmm.
If they do relax, then what do you expect the average number of cases to be per day? And if they don't relax, then what do you expect the average number of cases to be, to try and gauge what impact experts thought relaxing some stay-at-home orders would have on the population?
What would be fascinating is to ask people, would that ask those people the same question, like individuals living in a community, the same question, and how get at the behavioral economics of it, like how much of a risk would they be willing to take? So then you could get a sense of okay, if the risk is here, then I'm not going to the grocery store. If the risk is here, then I'm ready to get my nails painted.
Yeah, that's a really good point. I think what you'll end up, I wonder if you'll end up seeing kind of these classic availability biases, right?
Mm-hmm.
The fact that COVID's in the news more, maybe people will be a little bit scared, but I think you'll also kind of have optimism bias too. It's,
exactly,
it's more likely to happen
right
to you, not me, right? So maybe they would, I bet they would have very different answers than the experts. It'd be really neat to see.
Well, yeah, exactly. And I think that, that sort of is going to interact with state policy. People, when they feel like their government has some competence and it's okay, they're going to be more likely to go. I mean, I was just at physical therapy. I broke my ankle today, but I was listening to, they were right beside me, so I wasn't eavesdropping really. But they said, I really just wish I could go outside without a mask. And sure. I really hear them, I mean, and somebody said, well, I heard the state's going to turn green and then everything should be fine. So it really does matter, the policy and how people feel about what they do matters a whole lot from what I've seen. But
yeah, you're right. And if forecast, really the goal of providing information to people at the state level is because of the influence they have. That that kind of authority is a strong rhetorical technique, isn't it? And trying to give them the best information with these forecasts really helps them figure out when it's time to relax social distancing. Is it time? What sort of messaging should there be? What sort of marketing campaign should I put out ahead of time?
Exactly.
So, yeah.
Right. Almost using the information as a catalyst for change. Yeah, exactly. Hal, I want to make sure I give you the opportunity to respond as well.
So one of the things I've been very interested in is, first of all, there's been a lot of discussion around the influence of the government policy on people's behavior around COVID-19. But I'm also very interested in the other side of it, that how do people just naturally respond to information about a pandemic? And that usually takes the form of spirited discussions on social media with friends from high school and college and family. But I do wonder if there are signals that we could get from social media about people's likelihood for complying with the requests, or whether they would be likely to do social distancing and mask wearing regardless of requests, or if those signals will be swamped by noise, because we know that there are bot networks pumping information out to push opinion one way or the other. But I'm sure someone's working on that. It's not my field of research, but I'd be very interested to see how that works.
I'll plug my my past PhD lab. The University of Vermont's Complex Systems Center is working on that, trying to extract information from Twitter about coronavirus. So any of the 102 participants should take a look.
That's awesome. So we have another question. Can you speak to what kinds of systems would be required to capture race information and be able to include this as a key factor in future models? Such a great question.
You go ahead. Tom, you can talk if you want to, but I know now that the information is collected usually in reports. It's a mandatory reporting to the state, and I think that may be uniform across all states, but maybe not. The information is certainly available for confirmed cases, but where we would probably run into a gap or an information issue would be in cases that hadn't been confirmed, but were infected. But even getting a handle or a hold of that type of data is challenging and around privacy and safety concerns.
Yeah, I think you're right, Hal. It is collected in confirmed cases, but there's but the experts, and I think I also agree that there's many more unconfirmed cases than there are confirmed, and we don't have a good handle on that type of information.
One of the things I'm really curious about is how can we use, because one thing I love about your research, Tom, is including information that exists out there that people have into the quantitative data that may be delayed somewhat, and so these experts are able to give us input that we don't already have. I wonder how much, in terms of the forecasting, how far out would you guys feel comfortable in going and using sort of what you see in terms of the patterns between between or among some of these factors as sort of where we think this is going medium and long term?
Yeah, that's it's a good question. How far out are you willing to forecast, right? In a different infectious disease agent, seasonal influenza, that I've spent quite a bit of time with, we usually provide 1, 2, 3, and 4 week ahead forecasts from computational models. But we also ask this kind of like long-term seasonal information. When will the flu season peak? If it does peak, how intense will it be? And we did that same approach with experts too. We asked them for 1 week ahead forecasts of confirmed cases. Then we asked kind of medium-term questions. When will hospitalizations peak? And then we did also ask kind of end-of-the-year questions, like the annual death rate. So I think, but how far would they be willing to forecast things like the number of cases? I'm not sure. I don't think they would go much past a month. I don't think it's, in my opinion, I don't think it's fair to forecast past that. But or maybe if you did forecast past 1 month, your uncertainty might be so great that it won't be useful. I think kind of short to medium term forecasts are kind of most actionable for public health officials.
Sure, of course.
Yeah.
Al, do you have any thoughts about that? Anything you wanted to add?
I think, as Tom pointed out, that people get reluctant about forecasting too far out, and I think models should also be reluctant about forecasting too far out, because especially in this one, I think one of the big differences with this with the SARS-CoV-2, is that there's a much higher level of variability in the social interaction piece with shutdowns and lockdowns and people, and then recovery. Influenza modeling is on top of a sort of normal social interaction or a seasonal social interaction that's, I think, fairly stable. But Tom can correct me on that if I'm wrong. But the implementation of restrictions and the relaxation of restrictions, and it's different everywhere, I think adds a completely different level to this that might confound forecasting too far out.
Yeah, Hal, I think, when people ask me, why is it so hard to forecast infectious diseases, I don't understand. I tell them that it's not the infectious disease spread that's hard to forecast, right? That roughly follows an SEIR model with those assumptions. The difficult part is predicting social behavior. And people are hard to predict. That's the difficulty in infectious disease forecasting. We're all very complex, people, and that's what's difficult to forecast. Not the infectious disease spread itself, but really how we interact with one another and how it spreads that way.
One of the things I'm really interested in is the stroke belt in particular. Those states, and specifically Georgia and Florida, have been their state policies have been not as proactive, obviously, and not really even incorporating, in my opinion, some of the guidelines and advice from the Centers for Disease Control. Can you talk a little bit about the timing in terms of the forecasting of how this is going to play out across the country in different states?
Yeah, it's a tough question for sure. It's a tough question. I think different states, I think something important to remember is that different states are absorbing forecast information in different ways. Some states are really in close contact with forecasts and modeling teams and working with them, and other states aren't. Mm-hmm. So something, and instead they're kind of relying more on surveillance, more about reporting the data itself and looking at those trends and trying to make up kind of self-made forecasts. And mm-hmm. I think they could benefit. I think all surveillance systems in general could benefit from a more integrated forecasting approach. And that's something that we're doing. That's something we're doing right now with a team of 11 undergraduate students from Lehigh University. We're building an integrated surveillance and forecasting system specifically for the state of Pennsylvania, and forecasting at the county level, so all 67 counties of Pennsylvania, and they're working on it. But we're gonna provide one to 4 week ahead forecasts for each county of the number of new positive COVID cases, and we plan to do that at the end of the 10-week project. We plan to make those forecasts every week.
That's amazing.
So. Yeah, I think, and we hope that we're gonna approach the PA Department of Health, of course, and we hope that they take into consideration that information. But it depends on the state.
Yeah, no, we've had some great interactions with Secretary Levine, and actually a lot of potential collaborations are blossoming. So I can definitely see them being interested in this for sure. We have a few more minutes. Are there any closing remarks, or I have just a few things I wanted to mention, but just wanted to give Tom and Hal the opportunity to add any closing remarks from today's wonderful webinar.
This has been a great discussion. I'm glad we were able to do it, and I'm really happy that I get to continue to have these kinds of conversations with you and Tom going forward. So that's the best part about this for me.
Totally agree. I always love talking about statistical models and my research, and I think this is a fun platform to do that and kind of get the word out and get people talking about different ways to model COVID-19 outbreaks. The COVID-19 outbreak.
Absolutely. I want to just take a couple of moments and really one of the things that I have not seen as the dean of the College of Health here at Lehigh, and across the nation is really an appreciation for people who are on the front lines from the population health and the public health perspective. No doubt, not dismissing those who are on the front lines in hospitals and in emergency rooms and in clinical settings. But there are people like Tom and Hal who I think are doing incredible work to really help us understand from a population level what are some of the things that we can do to prevent people from ever having to go to the hospital in the first place. And so I think I just want to thank you both and just applaud the work that you're doing. And you're the unsung heroes. But I think it is important to put a shout out to the amazing work that you do that stands to really change the health of millions of people at a time. So with that, we're going to close up, and I thank you all for joining us. Our next Population Health Colloquium seminar is going to be in 2 weeks. So look out for an invitation for that webinar, and thank you so much for joining us today. and have a great day. Bye-bye.